All right, so we're pleased to welcome our presenters today. So Tara Resnick and Mario Sokas. Tara is a psychogeriatric resource consultant with the PRC program of Toronto and is based out of North York General Hospital. Tara has over 11 years experience in the field, as well as extensive knowledge and experience in both the long-term care and community sectors. She has a passion for dementia care, as well as supporting frail older adults and their caregivers, and she has extensive knowledge in behavioral management, as well as cognitive and mental health disorders. Tara is very passionate about education and helping to support staff in providing exemplary care and services to older adults. Mario is based out of the University Health Network in Toronto and has over 15 years of experience in geriatrics. He has been a PRC with the RGP of Toronto since 2009. In his role, he attends to the knowledge to practice needs of teams in long-term care homes, community support agencies, and LHIN contracted agencies in Toronto. Mario has participated in many committees and has supported the organizing of the Knowledge to Practice workshops and events for the Toronto Central LHIN Behaviours Support Ontario initiative since 2012. Both Mario and Tara are experienced facilitators with several of the key training programs that we offer within our behavioral support system, such as GPA, PIECES, as well as mental health first aid for seniors. So before we get started, I would like to let you know how to engage with Mario and Tara today. Please feel free to type any questions or comments that you have in the chat box at any time, and we are going to start our question period around 4:45. And we do know that you will want to know whether you can have a copy of the slides and a recording for this webinar, and absolutely you can. We will be sending them to you guys, the attendees, and then we'll also be posting it on our website and our YouTube channel. And so now I'd like to pass it over to Mario and Tara.
Lindsay, thank you so much for the introduction. Good afternoon, everybody. Welcome to the webinar where we're going to be discussing supporting persons with responsive behaviors in care settings. This is a part of a webinar series that the PRC team of Toronto has been facilitating for the last few months. So welcome. We look forward to providing you with information, whether it be new for some of you or whether it might be a new way of looking at responsive behaviors in your practice. So I just wanted to highlight a few things. As Lindsay mentioned in the introductions, the slide deck will be shared with you shortly following the training. It will be provided to you via email. And the webinar is being recorded and will be posted on the RGP YouTube channel. All previous webinars have been posted in the RGP of Toronto YouTube channel as well. And we highly encourage you to look back at some of the previous topics that we've discussed. Also, as Lindsay mentioned, please type your questions related to the content into the chat box. There'll be an opportunity for question and answer at the end of the webinar. Something to keep in mind, though, is although we recognize that there may be some case-specific examples that may require resolution, unfortunately, we will not be addressing these cases because of time, but we do encourage you to connect with behavior supports in your facility or in your care settings, as well as external behavior supports that exist to help support behavior management. So some of the goals for today's webinar is for you to broaden all of our understanding of responsive behaviors. As I mentioned earlier, some of you attending this webinar may have already have experience with responsive behaviors. What we're hoping to do is enhance what you already know and have a new way of looking at some of the concepts around responsive behavior management. We also want to look at the connection between cognition, emotions, and behaviors, and what are the implications of the way we interact with the person, keeping that in mind. Finally, we also want to identify various triggers for behaviors and really connect that by identifying the various triggers for behaviors, it will lead to action items that will help address the causes for behaviors and help improve the quality of life for the person living with dementia, but also help improve the quality of work life for our teams caring for persons with dementia. Whenever we do webinars, we like to get to know who is participating as an attendee. So we're going to be launching some poll questions for us to learn a little bit more about you. So the first question is, what is your role? We like to know who's attending as far as disciplines are concerned or professional backgrounds are concerned. So just take a moment and let us know, what is your role? And the results are in. We have the majority of attendees as nurses, and also the second leading group is other. And for those who are chosen other, if you could please in the chat box type out what your role is, that would be fabulous. We have 17% as occupational therapist, we have a physician here as well, a PRC, and also administrative. So welcome, thank you. We're going to launch the next poll question. How many years of experience do you have working in the field? All right, so the results are in. So we have 29% with 0 to 5 years of experience, another 29% with 6 to 10 years of experience, 21% with 11 to 15, 14% with 16 to 20, and 7% with 21 plus years of experience. I think what this means to us is that whether you have 0 years of experience, a few months a year of experience, up to 21 plus years of experience, we've all encountered responsive behaviors, and there's also wealth of knowledge and wealth of knowledge in this room. And like I mentioned earlier, for some of you, this information may be new, but for others, we might be offering you a new way of looking at what you already know. So thank you. Next poll question. Have you attended previous webinars in this series? And the results are in. So 23%, yes, you've attended, and 77% are no. So a lot of new faces here. So for those who are new here, welcome to the series. Again, I highly encourage you to go to the RGP of Toronto YouTube channel to view previous webinars that we've done. And for those who are returning, welcome back. So a key concept that we talk a lot about in dementia care, and in a lot of trainings that we facilitate in dementia care, such as GPA pieces, is that all behavior does have meaning. All behavior has meaning. In dementia care, what we look at is that this behavior is viewed as responses to unmet needs. The thing is, though, sometimes people with dementia are labeled by their behavior. And it's really important for us to recognize that, because if we label a person with terms such as aggressive, inappropriate, hoarder, or even agitated, it could give us these preconceived notions about the person. And in care situations, it could be labeled as a person being judgmental. It could be often viewed as being judgmental, but also prevents us as carers from really seeking the meaning behind the behavior. Something to keep in mind is whenever labels like that are being used, such as aggressive, inappropriate, hoarder, or agitated, again, with those preconceived notions that we have, if we hear those terms, we automatically think the worst, because aggression can mean so many different things to so many different people. And if we're thinking that this person might be striking out and might be kicking and thinking the worst, when we are going to be approaching this person for the first time, you know, our discomfort might show, and it can affect how we interact with the person at the end of the day. So it's really important that when we are using language to describe behavior, we're using person-centered language. So whenever I have discussions with teams that I work with, I always say avoid the 3 A's of behavior, behavioral description, which is aggression, agitation, and attention seeking. Quite often, as a care professional, whenever I hear these terms being used, I always ask the question to the teams. So you tell me that this person's being aggressive. Tell me a little bit more. What does that look like? So then I get a clearer understanding and clearer picture as to what exactly is happening with the person. When we use person-centered language, we start to move away from judging the person, exhibiting the behavior, and then we start to ask the questions, why is this happening? And the term responsive behaviors and all behavior has meaning really helps us get towards understanding that the person's actions has purpose and meaning. And we're also recognizing and valuing that the person with dementia, even though they are exhibiting behaviors, they are expressing their experience, and they do have the ability to express their experience. So this concept of behavior support is derived from 20+ years of evidence-based research, and it really highlights that behaviors occur due to the changes in the brain and the effect on specific brain structures. Something to keep in mind is that in our care settings, whether you're in long-term care, the community, or even acute care, a large percentage of people with dementia will have some form of responsive behavior in their journey with their illness. And also to keep in mind is behaviors, yes, they can be very frustrating to work with at times. And sometimes when we describe the behavior, it's out of the emotions that we do have around the behavior. And sometimes we view the behavior management as time consuming. But if we actually take the time to really figure out what is the meaning behind the behavior, and we come up with strategies that really address the problem, it can actually lead to very positive, rewarding outcomes and relationships with the person with dementia as well. So we want to hear a little bit more about what your experience is with responsive behaviors in your settings. So we're going to ask you on your browser or even on your smartphone, just pull up www.menti.com and please use the code above to answer the question, which responsive behaviors do you see when you're caring for people living with dementia in your settings? So we're just going to take a moment for you to put in your answers, because we really want to learn what your experience is with behaviors. And for those who may not be able to access Menti, if you could please in the chat box put in the behaviors, that would be fantastic. All right, the results are coming in. And this is all live results. And again, I should mention that it is anonymous. All right, so it's really coming in, my goodness. And I gotta say, what I'm liking so far is I'm seeing very specific descriptions as to what exactly the behavior is. Excellent. Something else that I also should mention is it goes to show the shared experience of participants in this room, because the larger the word means that the more people have actually inputted that word into the Menti poll. So far yelling and hitting is pretty up there, and also exit seeking, as well as pacing and pinching. And I gotta say, thank you. I have not seen any of the 3As yet. However, I am seeing good descriptions that could be categories that under any of those 3As, which is aggression, agitation, and attention seeking. Also looking at these behaviors here, yes, it can be very frustrating trying to manage the behavior. Or again, thinking about it, when we do find the underlying cause and we manage the problem at the end of the day, we're not only increasing the quality of life of the person exhibiting the behavior, which is the person with dementia, but we're also increasing the quality of work life for members of our team as well. And I could see that the results are still coming in. And again, a lot of similarities as well, but also some new behaviors coming in as well. Excellent. Okay, so thank you everyone for participating in the poll. It kind of really does give us an idea as to what your experience is, and we hope that with the information that we're going to share in the rest of this webinar, it can help us really understand where these behaviors may be coming from. So we're going to move on to the rest of the presentation. So again, thank you for your participation. So the thing is, when we're thinking about responsive behaviors or behaviors in dementia care, when we think about why a person might be exhibiting it is because a way of looking at the way the brain processes information is, and also how our behavior is guided, is through the ABCs of brain function. What we're feeling and what we're thinking at any given moment really does affect how we respond. And even for us as cognitively intact individuals who don't have brain disease, this process happens continuously in a seamless manner. The thing is, what ends up happening is what we're feeling affects what we're thinking, which will affect how we respond at the end of the day. But also what we're thinking will affect how we're feeling, which will affect how we respond at the end of the day. So the connection between feelings, thoughts, and behaviors really allows us to monitor our feelings. It really allows us to take action, but also evaluate how well the action addressed our feelings at the end of the day or addressed the situation. Now, when we think about a person with dementia, there's changes in thinking and perceiving, and that can affect the person's ability to accurately understand what is happening at the end of the day. So what we do see is a person has behavioral responses based on how they're feeling about the situation. They're not able to process what exactly is happening at that moment. And so what we do kind of see is kind of like a fight or flight response at the end of the day. So again, we said this earlier, that behavior does become the means by which the person with dementia communicates. And when we think about the ABCs of brain function and somebody who has dementia, the thinking is what really becomes impaired, and we do have that emotional response. And when we're interacting with the person with dementia, we may not be able to change what they're thinking at that moment, but we do have the ability to change how they're feeling. The thing is, behavior is a form of communication, as mentioned earlier, and something we also need to keep in mind is that a person with dementia is a unique individual, kind of like how we are unique individuals. So some of the strategies that we're going to talk about in this webinar we'll offer some tips and ideas to consider when we're interacting with the person and understand how the person's communicating. However, because a person is a unique individual, knowing the person behind the illness can really enhance opportunities for us to have successful interactions during care or any other situations. So something we need to keep in mind is that a person's behavior may be a response to really regain control, send a message to us, or protect oneself. We need to be the ones to figure out what are they trying to protect themselves from. Some behaviors, though, may be a way to alleviate boredom or to seek stimulation or companionship. If a person feels understimulated, their behavior might be their way of trying to tell us, hey, I'm bored, I need something to do. I need a friend, I need someone to talk to. The thing is, though, whenever we're working with behaviors, not all behaviors require our attention right away. Some could be harmless. But we need to stop and think for a moment. In our settings, how do we actually decide what behaviors require attention and which are harmless? So let's talk about high-risk behaviors versus behaviors of little risk. The thing is, when it comes to risk behaviors, it has to do with the context. But typically, high-risk behaviors are seen as behaviors that pose a risk to others or themselves. And it's typically physical behaviors. So let's say, for example, you have resident A and resident B, or patient A, patient B, or client A and client B. If the person strikes out to the other person, that other person is now at risk of harm. But what if the other person retaliates and hits back? Now the person who exhibited the behavior is at risk of harm as well. So we really need to look at the risk of physical harm. Another thing is that a person may be a risk to themselves as far as harming themselves is concerned. So you might have a person that might be having suicidal ideations or behavior that might indicate that the person may be considering dying by suicide. Also, exit seeking. You have a person with dementia who may be very disoriented to time and place that might look to leave the facility, and they might get lost out there, and it could lead to some negative outcomes. Also, eating inedible objects. You might have somebody might eat something which can poison them. Like, for example, you might have somebody that might take a bottle of Windex, drink it because they think it's something that they can ingest. Now, the behaviors of little risk, the first one where we're going to talk about wandering, again, it all depends on the context. Given now that the climate with COVID-19, wandering can be considered a high-risk behavior related to virus transmission. However, if we were not in a pandemic, wandering, depending on the context, can be seen as a low-risk behavior. So we have to ask ourselves again, why is the wandering behavior happening? Is the person seeking to actually leave the facility? Is the person entering other people's space, which could upset others? Or is the person just simply walking around in their environment, or just simply walking in the hallway? So it's really important for us to really look at the context that's happening in and determine risk there. However, again, given the current climate with the pandemic, we need to take into consideration virus transmission, which could actually increase the behavior to high-risk behavior. Something else that's a behavior of little risk is verbalizations. Again, if a person's calling out, that's typically little risk. However, again, thinking about it in the context of how others in the environment will respond to it, it could increase in risk. Again, we need to assess the context of the situation. Also thinking about times of rest. You might have a person who you approach to take them to bingo, for example, and they say no. Energy levels in all people can change due to many circumstances, such as sleep, the way a person's feeling emotionally, fatigue, feeling unwell. And sometimes a decrease in motor activity is just needed time to relax. So a person might be trying to tell you that they need some time to relax. Another behavior of little risk is dressing in layers. Unless the clothing becomes a hazard with walking or overheating, layering clothing may be a sense of comfort for a person with dementia. So something to keep in mind is that if a behaviors of lower minimal risk cause escalation to another co-resident, then we may need to increase the priority of this behavior to a high-risk behavior. So I'm just going to pass it on to Tara right now to take us through triggers.
Okay, thanks, Mario. So before we do a deeper dive into the different types of triggers we see when it comes to responsive behaviors, let's first define what a trigger really is. So a trigger is something in the internal or external environment that may cause the person with dementia to respond to a behavior. And that trigger is that quote unquote something that happens right before the behavior is seen. So as human beings, what we often do is assume, and that's natural, that's just sort of how we are. But rather than assuming we need to really, that we do know rather, or that we don't know, we should really always be stopping to ask ourselves the question, what is the reason or that underlying cause behind this behavior I'm seeing? Sometimes our assumptions are well-informed, sometimes they're not well-informed, and they're not really based on facts. So it is just really prudent for us to remind ourselves to ask that question, and even maybe, ask the question with the team after we've asked ourselves, and not try to fill in those blanks, and that will help us to avoid these assumptions that we make. A good rule of thumb is to always let our assessments guide our answers and not our assumptions. So now let's talk about the different types of triggers. And before we dive into that, sorry about that, I'm going to ask you the question. So again, we're going to ask you to take out those smartphones or open a new browser on computer, or if you have access to neither, please feel free to utilize the chat box. And we're going to ask the question, what do you think are some common triggers for behaviors? So if you're using the Menti, your code is 7816418. And again, that website is menti.com. So we'll give you a couple of moments to start entering in those answers. I think it's really important to mention, of course, that there's no right or wrong answer. You are all really the experts. We're all looking through very different lenses. We all come from different professional backgrounds, as we saw in our poll. And when we bring our minds together and look and bring all of the different lenses together, that interdisciplinary team, that's when the real magic happens and we start to really better understand all of our ideas and what we're seeing. And the responses are coming in. I see the chat firing up, so I'm just going to check if we've got any responses in there. Lindsay, I might call on you if you don't mind. It's not allowing me to access the chat. So if there are any responses, if you could just monitor that, I want to make sure everyone has their opportunity to voice.
Yeah, I can do that. Do you want me to actually read them out loud?
That'd be awesome. Thanks.
So we have a few coming in. Call bells or noises, constipation, and pain.
Awesome. Thank you. All right, so as we can see from the screen in front of us, the most common responses seem to be pain, unmet needs, absolutely, which is sort of that universal response. It encompasses all of the different types of triggers. Hunger, confusion. And then what I love about these Menti is, as Mario talked about a little bit, is that when we see these smaller font responses, that's when we're really starting to see all of our different ideas as well. So when we think about pain, absolutely, most common, I totally agree. But let's look at some of these other smaller font responses. So cannot express themselves, boredom, underlying health issue, amnesia. We're hearing some of the A's from those cognitive losses. I love it. Overstimulated, unfamiliarity, lack of sleep, constipation. It's moving fast, so forgive me if I'm not keeping up. Ultimately, though, when we try to make sense of the screen in front of us, what you can really see is sort of that idea I shared a few minutes ago, that because we're all looking through these very different lenses, we all have different experiences, we're all noticing different things, and if we don't come together and work as a team to share all of these ideas, we actually could stand the chance of missing out. Because as you can see in front of you, we have these really, really valuable responses and ideas. So thank you everybody so much for participating. And as you will see in the next few slides, you're absolutely right. You are the experts. You are bang on with your responses. So for the purpose of this webinar, we're going to break the triggers up into these four main categories. So the physical triggers, interaction triggers, also known as approach, environmental triggers, and social triggers. So we'll start with the physical triggers. So as we saw on our Menti, the most common response was pain. So you could say we read your mind. Let's start with pain. I often joke that I'm the pain police. When I think of responsive behaviors and I think about the physical causes for behavior, pain is one of the first things I always think of. And when we think about the population we're supporting, when we think about older adults, we know that pain is often underdiagnosed and it is very prevalent in older adults. Older adults living with dementia who are experiencing pain will also probably not, well, I shouldn't say probably, but may not be able to verbalize their pain. So in that case, behavior, as we know, is going to become their form of communication, and it's really up to us as their advocates to query pain. So we also have to consider their other diagnoses or maladies when we think of pain. So for example, arthritis or fractures or dental pain, to name a few. And this will really help us rule out pain as the trigger for their behavior. When I think of pain, I think it's really important to mention, to the best of our ability, knowing as much as we can about past injuries or diagnoses that may have resolved, or ailments. I think of myself, and I always use this example because I think it's really powerful. And I know, sort of as human beings, when we, in order to empathize, it's really helpful when we think about our own experiences. So when I think about my experience with pain, I had a fractured leg about 25 years ago, and to this day, when it rains, I have a lot of pain in the spot where it was fractured. And I always wonder, when I'm 85, if I'm living in a long-term care home, for example, and for whatever reason, I'm unable to let you know that I'm having pain in that leg, what do you think will happen if you try to touch my leg? I might kick you. And I have to be honest, I am not a violent person at all, but I do know that it is a basic human instinct to protect ourselves when we're experiencing discomfort or pain or feel threatened. So I always think of that because, again, I will be immediately labeled as that resident who's physically aggressive. But really, I've just got pain in my leg, and had we treated the pain, I wouldn't have kicked you. So I love to give that example because it's, again, something I think about often. So when we're thinking about the physical triggers, let's talk a little bit about hunger. So older adults who are hungry may not be able to ask us for something to eat. And what do we do when we're hungry? We grab a snack, whether we're home or at work or even in the car or, on public transit. We usually are able to locate food if we're hungry. However, if we couldn't do that for ourselves and we also couldn't verbalize that we were hungry, how do you think that we would show it? So thinking about things like wandering, when I hear about wandering, the first two things that come to mind, to be honest, are pain and hunger. Because what do we do when we're in pain? We don't usually just sit still and allow the pain to sort of just wash over us. We are restless, or we move around and we seek comfort. We try to find that happy place where we can find some relief from the pain. And to the same end, what do we do when we're hungry? We may walk around looking for it. If we don't know where to locate the food, you can bet that it's a basic human instinct to try to find it. So when next time you're supporting that older adult living with dementia who may be wandering or seemingly searching for something, think about these triggers, because it may actually help you identify those unmet needs when we're trying to manage these behaviors. And I also think of hunger when I think about folks who may be eating an edible object, so something else to consider as well. Dehydration, same applies, but I'll just throw this out there. When you're thirsty, you grab a drink. And if you don't know where to grab a drink, you're going to try to find a drink, or you're going to try to communicate to somebody that you need a drink. So same idea with dehydration. Toileting. So if a resident has the urge to toilet but isn't able to tell us that, or even really recognize the urge in some cases, they're likely going to show us with their behavior. And that ties into our next point about constipation. So it really, same as toileting, but I think it's also really important to mention the discomfort that can go along with constipation, oftentimes. So it's also really important for us to remember that just because someone has had a bowel movement, it doesn't necessarily mean that it was a good bowel movement. So when we're trying to rule out constipation as a trigger, I would encourage you to not just look at those records and think, oh, Tara had a BM, she's fine. Doing that deeper dive and better understanding will help rule out constipation. Infection is another huge trigger when it comes to responsive behaviors, and we'll know because we're going to be looking for things like sudden changes in behavior or discomfort, possible delirium, and we're going to talk a little bit more about delirium on the next slide, so I'll save it for then. Sleep. I will just throw this out there, and you don't have to answer me, but you can ask yourselves the question: if you are sleep deprived or you had a really, really bad night's sleep, are you in a great mood? Because I can tell you with absolute certainty that I'm not. And I'm a pretty happy person, a pretty high energy person, but if I have not slept well, I am not the happiest. So something to keep in mind, the same would be true of our resident or your client or patient. If they've had disrupted sleep, they may be more likely to become irritable or exhibit responsive behaviors. So a deeper look at their sleep patterns may actually help us to rule this out. Thinking about diseases. So considering other diseases or diagnoses that may be triggering behavior. When we think of responsive behavior, oftentimes the first thing we jump to is that diagnosis of dementia. But I would argue the first thing we need to jump to is everything else. So what else is going on? Because as we know, as we've already identified, responsive behaviors are in response to an unmet need. So a great example that I can give you from my past life when I worked in long-term care was a resident who actually was quite calm during the day, didn't really have any behaviors, and then whenever staff would help her get ready for bed and then help her get to bed, as soon as she was in bed, she would start screaming and jerking her bed around and yelling and crying. So we sort of immediately tried to rule out your usual suspects. Does she have pain? Is she lonely? Is it the environment? Is she scared of the dark? So on and so forth. Long story short, she had COPD. And when she was laying flat in her bed, she was short of breath. She couldn't breathe. And when we think about that, any one of us would be screaming, yelling, swearing, doing whatever we could to alert the people who are supporting us that, hey, I need help, I can't breathe. So that's an example I always think of when we think about considering the other diagnoses. And then mobility problems. So is the resident experiencing mobility problems and possibly forgetting that they can't walk, or are they in a wheelchair with a personal assistive safety device and can't understand what it is or why they need it? So something to rule out as well. And we have to really remember when it comes to our physical triggers, let our assessments guide our answers and not our assumption. So I'm going to briefly touch on delirium, recognizing, of course, that delirium in and of itself is a whole webinar topic. But when we think about physical triggers, we always have to think about delirium as well. So we know that older adults, due to the aging process and multiple health issues, are at higher risk of developing delirium, which, as we also know, is a medical emergency and can be fatal. So when you are supporting older adults, when you notice a quick change in their behavior, always query a delirium. And I always support staff to report it no matter what. I know as human beings, sometimes if we're not sure, we're kind of on the fence. We think, well, should I say something or shouldn't I say something? When it comes to delirium, I would encourage you to always say something, because the worst case scenario is that the person doesn't have delirium. And the best case scenario is that you've just saved someone's life. So always report if you suspect and be very suspicious. So next, we're going to talk about those interaction triggers, or what some might refer to as approach. So what's really interesting is that as human beings, 85% of the message we send each other is nonverbal, and that's with or without dementia. People with dementia, however, who, for example, might experience loss of language, are going to use that nonverbal, which we've already established is super loud. They're going to use that nonverbal communication to understand what's being said. So we have to be really cognizant and aware of our nonverbal communication. So thinking about things like body language and our body position. So that would be things like, crossed arms versus uncrossed arms. Just by crossing our arms, we're sending a completely different message than we would be had we left our arms uncrossed. Thinking about facial expressions. So something like a smile. A smile goes a really long way. Even with a mask on, you can tell when someone's smiling. And hand gestures. I talk with my hands. If you could see me now, you'd see I'm doing it right now, even though I'm at a webinar and you're not here with me in person. But if I was doing that with an older adult living with dementia, they may misconstrue that as me trying to hit them or striking out, and then they misconstrue it as a threat, and that may trigger a behavioral response. So I'm really aware of my body language at all times when I'm with patients, residents, or clients with dementia. And then considering our voice, so our tone of voice. Are we assuming that the resident can't hear us and therefore maybe we're speaking loudly? We know that this could obviously be misconstrued as yelling if we are, and is our tone therefore sending the wrong message? So another example of that might be, are we tired and sending the wrong message with our tone, or frustrated? Are we talking too fast and the pace is too hard for the resident to follow, causing frustration and then a behavioral response? I'm talking very fast right now, and I'm aware of that, and it's in the interest of time, but I do talk very quickly naturally. And when I'm working with older adults, I have to be really aware of that, because I could be triggering someone when, of course, all I mean is well. And then lastly, language. So thinking about things like language barriers or aphasia. We know that we live in the most diverse city in the world. So utilizing things for both language barriers and aphasia, like communication cards or cues or gestures or objects to the best of our ability. And then also just trying to be mindful of our words. So trying to use really simple language as opposed to something like medical jargon, for example. Let's talk a little bit about those environmental triggers. So I would often say that no matter what, when you're supporting somebody and you are trying to understand a behavioral response, take that moment to do a very quick environmental scan, because oftentimes in doing that, you may notice a trigger in the environment that you wouldn't have otherwise. So thinking about things like clutter or crowds or color. So, when I think of this, I think, for example, of something like a crowd. Some of us don't thrive in a crowded environment, whereas some of us do. But if we, our whole life just didn't do well in crowds, and now we're living, for example, in a long-term care home and we're eating with multiple other people for every single meal, that in and of itself can be a trigger. So knowing as much as we can about the resident, we're going to talk about that more in our next slide, will always be our best friend. So the more knowledge we have of the person and their past and their likes and their dislikes, the better care we can provide. I'm thinking of things like overstimulation or understimulation. So I get overwhelmed very easily. So what I mean by that is, if there is, two people having a conversation to the right of me and three people having a conversation to the left of me, plus the TV's on behind me, plus in front of me I see a radio, it's a lot. I have a really hard time focusing, and it flusters me. So I think of myself in that situation always. And then, I also think of myself when we think about being understimulated. I'm very active. So if I was bored, and I think if any of us are bored as human beings, what do? We look for something to do. And that may actually look more like a responsive behavior when really it's just boredom. Unfamiliar environments and or routines. We can't always do something about this depending on the setting in which we work, but we can always do our best. So if there's anything we can do to help familiarize the environment, whether that's pictures of familiar people or a favorite blanket or a favorite doll or a favorite stuffed animal, whatever it is, if we can help provide familiarity and structure to the routine, that's always a huge help. And lighting. So whether that's, fluorescent lights, I'm triggered by fluorescent lights. I get migraines, but if I couldn't tell you that and I was in a room with fluorescent lighting for a couple hours, I would likely show you that with my behavior. Or maybe there's a light that's flickering that's bothering me. I always think of shadows as well. So, there might be a piece of furniture which we'll notice in that environmental scan that we're doing that's creating a shadow in the room that is, the person may be misperceiving. So it may look like a scary monster, for example, and we can really easily eliminate that trigger by just removing whatever it is that's creating the shadow. So that's, of course, just one example of many, but something to keep in mind. And people in the environment as well. So, are there too many people in the environment, as I mentioned when I spoke about crowds, or is somebody yelling beside me that's triggering me, or is someone banging on their table to the left of me that's triggering me? So thinking about that. And then whenever we think of environmental triggers, just briefly, I think it's important to also think about things like having the news on at all times. So a lot of the times we see something like CP24 on constantly, which is great. I love CP24. But when we think about older adults living with dementia, it can be quite distressing. Let's be honest, for a lot of people, it can be distressing. But for older adults with dementia, it could also be misperceived, and they may think it's actually real rather than on TV, and that can trigger a behavioral response as well. So lastly, we want to think about our social triggers. So it is really important to know as much as we can about the person's life story or past roles. So what did they do? What do we know about their family? What do we know about their upbringing? What do we know about any different specific roles they may have held? So I can give you a great example. One of the homes I support had a resident who every night was going in and out of every resident's room on the unit, and they could not get him to stop. They tried everything. So long story short, we discovered that he was a security guard his whole life, and he was just doing his rounds. And when we think about it, if no wonder he wasn't stopping. If I came to any of your work and I said to you, stop doing your job, you would probably tell me where to go. So what we did really simply was the intervention was we had a staff member go with him once, and he didn't go in the rooms. He just peeked in, stayed outside, but looked through the door, went to each of the rooms. And then after he did one round of each room, they would say, okay, your shift is done. Thank you so much. You can go home now. And he would go to bed and he would settle. So it's really this idea of stepping into their world rather than trying to bring them to ours, and knowing their life story can really help us do that. Also really important to know when possible if there's been a history of trauma. So some examples of that would be possibly a near drowning, and maybe we're trying to give the person a bath, or maybe we're putting somebody in a shower who lived through the Holocaust or a lineup. So knowing as much as we can about those histories of trauma, if at all, or if any rather, and then as much as we can about likes or dislikes. So we all need to know what each other likes, or conversely what we don't like, in order to support each other well. So again, I'm not a violent person, but I despise peas, and I always have. So I know with certainty if you were giving me peas every single day, I would get to a point where I'd get so frustrated that I'd probably throw the plate of peas. And instantly, again, I'm labeled as a person with behaviors, when really, just don't give me peas. So one example of really why it's important to know people's likes and dislikes. And then thinking about, again, this idea that we do live in the most diverse city in the world. We need to do the best we can to know as much as we can about our patients, residents, or clients' cultural needs, as well as their spiritual or faith-based needs, and do our best to meet those needs. And then lastly, changes in visiting patterns. So this is especially true right now in the time of COVID-19. People who may have visited frequently and regularly may no longer be doing that, and the removal of that support can be quite triggering. So just an idea, an example rather of what we could do in that case, because we obviously can't produce the person, but we could get creative and work with the loved ones to create, like a 30-second to 1-minute video of them saying, hi, I miss you, I love you, I'm gonna see you soon, everything's okay, that we can play for the person to help to intervene in that respect. So that's just one example of many, but the idea, of course, is let's get creative. When it comes to managing responsive behaviors, we need to tap into all of our creativity, all of our empathy, and do our very best to know the person behind the disease. So we need to remember that all behavior has meaning, and for us to provide that amazing person-centered care, we really need to address the reason behind the behavior. So before we open it up for questions and answers, I'm just going to share a couple of resources that we thought would be of value to you. So the first is a resource from the Center for Learning and Research Innovation, and it's called Understanding Dementia. The next are through the RGP. So the first one is guidance for supporting residents who wander and require physical isolation, and then supporting individuals with responsive behaviors across sectors during COVID-19. And then the last two are actually opportunities for further learning. If you're interested, we would encourage you to check out Age Inc., Gentle Persuasive Approaches, as well as the Pieces Framework. And lastly, we want to thank every single one of you. Thank you from the bottom of our hearts for supporting persons living with dementia and for this super important and valuable work that you do. You're making such a difference in so many lives every single day, and we applaud you and thank you for everything you do. So we'll also ask you, we're going to send out a survey. You're welcome to use the chat box as well. We want to ask you if there are any other topics you would like to see for future webinars. Please let us know. We love to hear from you. And with that, we will open it up for questions and answers.
All right. Thank you so much, Tara and Mario, for sharing your expertise and taking us through this great overview of responsive behaviors. You covered some very important information and really highlighted the importance of finding the meaning behind the behavior. There's one thing that I really love most, and that was just when you were talking about the difference between those high-risk behaviors, that might require attention or, intervention, and then those ones that, might be more minimal risk. So, particularly how the level of risk can change depending on the context. So, you talked about wandering and how that's typically a low risk behavior. But then in our current context of COVID-19, it becomes a priority. So I just really like that.
Yeah, thank you, Lindsay. Honestly, context changes everything. And again, given the fact that we are in a pandemic right now, will change our response to certain behaviors that we may have seen or viewed as low risk before. So I guess the key message is, even wandering, understanding the meaning behind it, that's how we're going to truly manage it at the end of the day. So really taking that time, investing that time with members of your team to really trying to figure out, why is this person wandering, or any of the other behaviors that we mentioned, or that you mentioned, I should say, in the Menti polls. Really taking that time, investing that time in the long run is what's going to save us the time by really addressing the problems, because we know what the cause is at the end of the day.
Mm-hmm. So we do have time for questions. We do have one. So medications are typically considered for behaviors for a quick fix. So how would you encourage staff to consider non-pharmacological approaches?
I mean, I think it goes back to the whole concept that all behavior has meaning at the end of the day. If you actually look at the meaning behind the behavior, would antipsychotic medication truly address the problem? So, I mean, Tara talks about, she really advocates for good pain management and good pain assessments. If a person's in pain at the end of the day, antipsychotic medication is not going to reduce the pain. It's just going to maybe mask certain behaviors, but it's never going to truly eliminate the behavior. I can tell you a story about a client with dementia a few years ago that I helped supported a team with, that the person basically, no matter how many times they changed their antipsychotic medication in a matter of a few months, her behavior wasn't going away. And when they called me in to do a case discussion, a knowledge to practice case discussion, always the question I was asked, have you ruled out all physical causes first? And they're like, Mario, we can't even get close to her to rule out the physical causes and do an assessment. So the call was to have her transferred to an emergency room or emergency department where they had a good geriatric emergency management program. And they did a really good thorough assessment. And as Tara mentioned about bowel movements, just because somebody's having a bowel movement, that doesn't mean that they're having a good bowel movement. And in this particular person's case, she was having not good bowel movements, and they found about over a year worth of feces inside her. Once they cleared her out, she was doing fantastic after. But it goes to show you how many times they changed that antipsychotic medication, did nothing. So it's always thinking about, what are the underlying causes. And Tara also mentioned earlier the story about the person who was a security guard. Medication's not going to erase a person's life story. Medication's not going to erase a person's past roles as well.
I totally agree. And I think just to sort of piggyback off that for a moment, when we think about all of the beautiful non-pharmacological interventions that we all come up with as healthcare professionals, they're not going to work if we don't treat the root cause first. So when we think about things like pain or constipation or those physical causes, if we don't rule those out and treat them first, it doesn't matter what you do. If I'm in pain, my behavior is not going to stop. Because I am in pain and I need help and I need that support. So I think it's really important to remember that as well. And antipsychotics, as Mario said, are not going to treat that root cause unless it's a psychosis.
Absolutely.
It's interesting.
Are you going to say something?
It's actually interesting. Earlier in the previous group, there was a comment made about the time it takes to manage behaviors, and it goes back to the whole thing that if you invest the time, you save the time in the long run. Because what takes more time at the end of the day, dealing with a behavior that we don't know the cause for, and our approaches and our interactions are not successful and not getting the task done, or investing the time thinking about the collective knowledge and experience in this room, but also collective knowledge and experience in teams, and really gathering that information together to really get to that root cause of the problem. and then putting the strategies in place that are truly going to address the cause. So we're going to be saving the time in the long run at the end of the day. So really taking that time, invest the time, you save the time, and we lead to great outcomes, which makes the work that we do so rewarding and we feel good about it. As I mentioned earlier, it's not only just improving the quality of life of the person with dementia, but it's also improving the quality of work life for members of the team as well.
Absolutely. There really is no quick fix, right? We need to find out what that behavior is.
Not at all. Yeah.
There's no other questions coming through right now. So I guess we'll start to wrap it up. So please, I just want everyone to go in the chat box and thank Mario and Tara right now because they're amazing and this webinar was great. So give them some love. But I just want to thank you both for this great learning opportunity. I feel like there's always so much that we can learn when it comes to dementia and behavioral expressions. And, you know, I think we just need to reiterate to folks today that, you know, not one person living with dementia will be the same as another person living with dementia. And we really have to be that detective, you know, to figure out what's causing, you know, the person to behave in the way they are. And it does take time, like Mario said, and it can be challenging, but if we work together with our teams and our external partners and the individual themselves, then we will be able to make a difference. So thank you. And then thank you everyone else for attending this webinar. You will receive a short evaluation survey by email, and you can also go to the SurveyMonkey link there as well. And give us your feedback and let us know if you have any suggestions and topics for the future. Okay, and thanks, and we'll see you again soon.
Thank you.
Thank you. Thanks so much, everybody. Take care. Stay safe.